A very good evening, everyone. So we are back again. And again, this is session 2 for NEET PG top topics. So I have an important announcement before I start this session. It is that I will be taking a class on ophthalmic equipment. That means that would include the instruments that we use and the instruments used in the surgery, in the OT, on Unacademy app on 29th, which is Thursday, 29th June, and that is scheduled for 5 p.m. right? So that's a class basically which is image based, which has all the ophthalmic equipments and the surgical instruments which are important from exam point of view. Right, so that is on 29th June, 5 p.m. That is on Unacademy app, and it's a free special class, right? So, and let's see before we start what other things are there that Unacademy has to offer us. Well, it is presenting with NEET PG Vitals, which is giving us recorded videos of 800 comprehensive videos, 800 hours plus of comprehensive recorded videos, which you can listen to, which you can see, which you can make notes from at your own convenience. Right, so you can subscribe to that. And then also for FMG aspirants, we have the All India Medical Test, which is scheduled for 25th of June and from 11 a.m. to 4 p.m. And then we have an FMG 2023 test series. So it's a test series which is targeting FMG 2023 exam, starting 14th June onwards till 30th of July. Also for FMG, in addition to the above two, we have FMGE Rapid Booster Batch, which is actually a mentorship batch which has 10 hours of live mentorship by all our top educators. And the ones who are targeting next, we have ACE Next, which is targeting next this year, or NEET PG 2024. All are at very subsidized prices. So we'll be happy to have you on the platform with us. We will all be in it together preparing for the D-Day, right? And any additional benefits, you can use my code Bhumika. So with all this, hi Swami, Prakhar, Shivangi and Divya, a very good evening. And let's start the session of NEET PG top topics. This is the session 2, and all these topics are in addition to the topics that we have discussed in the previous session, that is session 1. Right, so let's see. So when I show this image again, I say I do not like to give you options, and all my students know why. So let's see. So now I would name this image as A, B and C, and you have to tell me which signs are this. What do you call these signs? A, B and C. For your convenience, I have given what is seen in the image here. So tell me, well, I knew you would all write down the diagnosis, but well, I do not. I am not looking for the diagnosis as of now. Well, there is just the one word all over in the chat box. But before I get to that, I know you all know the disease, but what I am interested is the first question that comes is, tell me what is image A? Which sign is this? All right, all right, all right. See, exophthalmos is different. So you already have this word written here, which talks about upper and lower eyelid retraction. So what you get in image A is basically eyelid retraction. How do you get to see this retraction? Well, when we talk of the normal position of the lids, please listen to me. When we talk about the normal position of the lids, let's see how it is. When we talk of the normal position of the lids, this is a cornea. Okay, I'll make it a little smaller. When we talk of the normal position of the lids, this is how we draw it. So you have to tell me Now you have to tell me what is the normal position of the lids, right? So let's talk about the normal position of lids, right? So when we are talking about this, we all know this is medial canthus and this is lateral canthus. So tell me first, out of the two, the medial and the lateral canthi, the cantha is the one where both the lids meet. Which one is higher? First tell me which one is higher. Oh, hi, we have somebody joining us from Zamibia. Good, Zambia. I'm sorry, Zambia. I'm sorry. All right. So first you have to tell me out of the medial and the lateral canthus, which one is higher? Which one is higher? Which one is higher? Is it medial canthus or is it lateral canthus? So by that I mean if we draw a line which is from the lateral canthus, so which one will be higher? This is not correctly made. Which one would be higher? Tell me. Yes, so it is the lateral canthus which is higher as compared to the medial canthus. As compared to the medial canthus. So lateral canthus is, this has gone a little, it is like this actually, right? This is like this. So the lateral canthus is higher than the medial canthus. Point one. Then when we talk of the normal position of the lids, when we talk of the upper lid covers, you are absolutely right, 2 millimeter from limbus. Right, it covers around 2 millimeter of the cornea, which is, it covers about 2 millimeter of cornea from the limbus, whereas the lower lid just touches the limbus, just touches the limbus. Right, so this is the normal anatomy or normal position, and this is called as the palpebral fissure. This area which is seen here is called as the palpebral fissure. Right, so now here if you see in this image, what do you see? You see scleral show. What is seen? There is scleral show. That means the upper lid is not covering the 2 millimeter of cornea, which normally it should. So this is an eyelid retraction. So this is upper eyelid as well as lower eyelid retraction. So do you get that? So this is upper eyelid and lower eyelid retraction. And which sign is this? Absolutely right. This is called as Dalrymple sign. This is called as Dalrymple sign. So now we come to image B. So image B says there is lid lag in down gaze. Which sign is this? Tell me. So lid lag in down gaze, lid lag on looking down, lid lag on down gaze is which sign it is? Tell me, which sign is this? Lid lag on down gaze is which sign? Yes, this is the von Graff's sign. This is the von Graff's sign. And third is there is inability to close the eyes. There is inability to close the lids completely. So if you see here carefully, there is inability to close the lid as it should be like this. So this is called as, which sign is this? This is called as, what is this called? Inability to close the lids completely is called as, no, it is not ptosis. What is it called? This is called as lag of thalamus. So inability to close the lids completely, to close the eyes completely is called as lack of thalamus. So now when I talk to you about these three signs, which disease am I talking about, which you have already answered me? We are talking about the thyroid eye disease, or it is called as Graves' disease, or it is called as Graves' ophthalmopathy. And I have discussed with you some 18 signs of thyroid eye disease in my courses. So you must know them. You must learn about them. So now you have to tell me what is the most common and the first sign, first clinical sign to appear out of these three. The most common and the earliest clinical sign is. Now tell me. All right, so when you write, there is a comment on here, hyperthyroidism. So thyroid eye disease or Graves' disease or Graves' ophthalmopathy is associated in 90% of the cases with hyperthyroidism. It can be associated with the euthyroid state, or it can also be associated with 1% of the cases with hypothyroid state. But important thing is that it should have these autoimmune markers for thyroid disease or thyroiditis. Okay, so it should be well documented. All right, so now you have to tell me which is the most common and the earliest clinical sign out of these. It is not Graves' sign, so I will mark it here like this. The question here is the most common and the earliest clinical sign is this. So it is the Dalrymple's sign. Dalrymple's sign is the most common and the earliest clinical sign. So now the question comes that you have to tell me what is the most common cause of eyelid retraction. And this is A, and B, you have to tell me most common cause of unilateral or bilateral proptosis. Tell me. So let's answer A. What is the most common cause of eyelid retraction? What is the answer? So the most common cause of eyelid retraction is, tell me, what is the answer? Anybody wants to attempt to this? What is the most common cause of eyelid retraction? Anyone? All right. So the most common cause of eyelid retraction is thyroid eye disease. And what is the most common cause of unilateral or a bilateral proptosis? What is the most common cause of unilateral or bilateral proptosis? Come on, tell me. The most common cause of unilateral or bilateral proptosis is again thyroid disease, right? So now we come to, so which is an important topic here? So the important topic which you must remember, which you should know is, I will mark it here, is thyroid eye disease is very important, or Graves' ophthalmopathy or Graves' disease, right? So this is thyroid eye disease. All the signs, all the diagnostic modalities, we have 2 out of the 3 signs should be positive, which is either the clinical testing, which is the your thyroid status, number 2 your ocular signs, and number 3 the imaging. So 2 out of 3 signs should be positive if you want to diagnose as a thyroid eye disease. All right, so next we move on to this image. Now you have to tell me, identify this image. What is the diagnosis? No, Rohit, it's not cellulitis exactly. It is basically what is linked to the muscles. So thyroid eye disease is per se is not cellulitis, right? It's basically all related to the muscles. All right, now tell me, identify this image. What is the diagnosis? All right, I think it's too early to say dot spots. No, let's see what are we seeing here. So basically what you have is, let's first write down what are we seeing here. So what are we exactly seeing here in this image? Let's write down here. So what do we have? We have hemorrhages, right? So hemorrhages are present, not 360-degree. So where are the hemorrhages present? Are they present in this area? No. So they are just present inferior and inferotemporal. Okay, let's see. Now I will zoom in this image if you want to see. Anything specific that you can see here now? So first we wrote down there are hemorrhages which are present in inferotemporal plus inferiorly. Okay. What is the other thing that you have? You have these. What is this? What are these? What is this? Tell me, what are these? This is not retinitis pigmentosa. First, you tell me what is this? These are the so if I mark these are the cotton wool spots. So this is the second thing that we see. Now if I zoom it here maximally, and if you try to look here, there is this vein which is going, but now after this point we are unable to trace, right? So see carefully, there is a vein, there is an AV crossing here, and after this point we are not able to localize the vein. So now you tell me, what is this? This is not diabetic retinopathy. Diabetic retinopathy would not have hemorrhages which is localized to one quadrant. See beautifully, they are so localized to this quadrant. Diabetic retinopathy will have 360-degree hemorrhages and cotton wool spots. So here all the findings are localized to inferotemporal and inferior retina. So now, no, this is not hypertensive retinopathy. Hypertensive retinopathy would again have hemorrhages which are present throughout and will have AV crossing changes. I agree. But here what we have is, if I tell you there is a blocked vein, the vein is here, but you cannot see anything beyond this AV crossing. There is no vein seen. We are unable to continue. If try to trace this vein after this point, I cannot continue and tracing the vein. So what is it? Now tell me, what is it? No, it is not CRVO. What is CRVO? CRVO is central retinal vein occlusion. What is this? This is when you have hemorrhages on all the four quadrants. But no, here it is not in all the four quadrants. It is venous occlusion. So it is a branch retinal vein occlusion. And why? So let's write down first. So we have BRVO. So what is BRVO? It is a branch retinal vein occlusion. So now what are the findings here is, please note, these are the cotton wool spots. There are hemorrhages which are limited, which are localized to the involved area. Right? So all the findings, please note down, the findings here are localized to involved quadrant. Just give me a minute. right? So these are all the findings are localized to the involved quadrant. So you have hemorrhages, you have cotton wool spots, you have a blocked vein. Everything is localized to one area, right? But what you said right now, when we talk of CRVO, CRVO is something which is involving all the quadrants because it is involving the central retinal vein. Right? So do you get this point? So branch retinal means the findings which will be along that branch which is involved in the venous occlusion. Whereas when we talk of this image, so what is the difference between this image? This is, let's name it as image A and image B. So now if you talk of CRVO, this is CRVO. So what are the findings here? You have hemorrhages in all four quadrants. You have hemorrhages in all the four quadrants. Do you get that? So that is central retinal vein occlusion, right? So when we talk of branch retinal vein occlusion, you will have hemorrhages, you will have cotton wool spots along that one particular quadrant of the vein involved. Whereas when we talk of the central retinal vein occlusion, you have all the four quadrants which are involved. Is that clear? So now that is no confusion. Yes, that gives you a splashed tomato appearance, but that is seen in central retinal vein occlusion. So we'll just come over to that. First, let's talk about BRVO. So now the question comes here is, the next question to answer here is, when you talk of BRVO, what is the most common site of occlusion? Tell me, the most common site of occlusion in BRVO is? Site of occlusion in BRVO is? I just showed you here. This should not be a mistake now. I just showed you here. What is this site? Okay, that is the, Rohit, what you're answering to me is superotemporal quadrant. I take that. That is the most common quadrant involvement. So there's a difference now. I'm asking you, what is the site of occlusion? Most common site of occlusion. You get that point? And what you are answering me, yes, Vinage. This is absolutely right. Ganesh Vinige. If I pronounce it right, I'm just apology if it is wrong. It is absolutely right. So the most common site here is the AV crossing. Is the arteriovenous crossing. And what you said, most common quadrant involvement, if I say, you are right, it is superotemporal. So now you get the difference. So when we talk of a venous occlusion, it is the artery over the vein which is compressing. All you said was hypertension, diabetes, hypercoagulable states. All those are the causes which lead to a branch retinal vein occlusion. So now there should be no confusion. When we talk of venous occlusions, we get hemorrhages, we get cotton wool spots along an involved quadrant. That is venous occlusion. When we talk of arterial occlusion vis-a-vis, arterial occlusion, as we discussed, there was someone who asked in the previous session also. So arterial occlusion would be a pale retina. So if the retina has hemorrhages all over, it could be diabetic retinopathy, it could be central retinal vein occlusion, but then diabetic retinopathy, he will have other changes, like it will have microaneurysms, venous bleeding, erymas, all those things. But like this, a tomato splash appearance, it's like you splash a tomato on the wall, it just spreads all over. So when you have hemorrhages in all the four quadrants, which are massive all over, what you think is, you think of CRVO. What is CRVO? It is the central retinal vein occlusion. All right. So now no confusion. So then we know it is of two types. It is ischemic central retinal vein occlusion and non-ischemic central retinal vein occlusion. All the findings, all the changes have been discussed in detail in the course itself, which has been separated for FMGE and next. So you can go through those courses and you can learn through them. But ischemic, non-ischemic, important. Another important thing, I have told you there has to be hemorrhages all over. And then another important thing is, what is the very important complication that you should know of CRVO, and not to forget the tomato splash appearance. So basically, when we talk of a splashed tomato appearance or tomato splash appearance, it is the appearance which is like or which simulates the hemorrhages all over. And then you should be able to tell me what is a very important complication of CRVO. Tell me. Important complication of CRVO, which you must never forget. And the fancy name also. Tell me. RD? No. No. Very common complication. See, what you're leading with from ischemic CRVO, there is increase in vascular endothelial growth factor. There is ischemia. There is rise in VEGF. Now I'm giving you hints. Come down to it. So once the VEGF raises, I explain every sequence to you in my session, in my class on venous occlusion. So what is? Yes, there is neovascularization. So the important thing is there is neovascularization ultimately leading to NVIs and neovascular glaucoma. So when we talk of NVG, neovascular glaucoma in CRVO, what is the fancy name which is given to this? Tell me. The particular name or particular something special we called to neovascular glaucoma post CRVO. What do we call it? Anyone? Tell me, what do we call it? It's something to do with the calendar. So that's another hint to you. Something to do with the calendar, with the months, with the number of days. So now you should be able to answer. These are a lot of clues to answer. Yes, very good, Ganesh. So it is called as a 90-day or a 100-day. It can be 90 days or it can be 100 days glaucoma. So all the older books write it as 90 days glaucoma. By days, we just basically mean to say that this is the duration which is required for the process to develop to neovascular glaucoma. Is that okay? So now you should not forget this. So, and this neovascularization can lead to vitreous hemorrhage. All right. So whenever we talk of central retinal vein occlusion, hemorrhages in all the four quadrants, splashed tomato appearance, 90 days or 100-day glaucoma, ischemic and non-ischemic type of CRVOs is very, very important. Is that clear? Now give me a thumbs up if this is clear, then I'll move to the next one. Okay, so now we come down to this question. There's a male with a history of liver disease who developed a cataract as shown in the image. Which substance is deposited in cornea? So now before I come to answering this question, you have to tell me, what do we see in image A and what do we see in image B? Tell. Leave all the questions aside. We need to learn something in this session. We're not here just to answer the questions. So you have to tell me what is seen in image A and what is seen in image B. I know you all know the answer. Yes. So sunflower cataract. Which is the sunflower cataract? Is it A or is it B? Now you please listen. These two images are not of the same thing. It's not depicting the same thing. A is something different. B is something different. All right, so I have some answers. Sunflower cataract, case of flesh-shearing, posterior subcapsular involvement, B. What is, okay, so you mean to say basically that in the image B, what we are seeing is a sunflower cataract. All right, I take that. This is a sunflower cataract. What about this? What is A? Okay, I'll start with the hints. Can you see something here? Brownish discoloration here. This is exactly what Baljinder Kesahi has answered. This is the KF ring. This is the KF ring. So basically what we are dealing with, the Kayser-Fleischer ring, sunflower cataract. Which disease are we talking of? Which disease are we talking of? So basically when we talk of the sunflower cataract, this is the cataract which has a brownish discoloration in the center with like the centrifugal extensions, right? So that is a sunflower cataract. KF disease, absolutely. What we are dealing with is the Wilson's disease. What we are dealing with is Wilson's disease or hepatolenticular degeneration. Absolutely. And Wilson's disease is the disease which affects which metabolism, which you all have answered correctly. It actually affects the copper metabolism. Very nice. Now you have to tell me, when we talk of Wilson's disease, when we talk of hepatolenticular degeneration, in Wilson's disease, we talk of KF ring. So when we talk of the KF ring, out of image A and B, which of the two images affects the or causes visual impairment? Now answer this. A or B, which of the two images, A, that is KF ring, or B, sunflower cataract, which affects the vision? Which causes, or what out of the two causes visual impairment? Okay, so I have the answer B coming from Rohit and Baljinder. Anybody who tends to differ with this? Which out of the two causes visual impairment? Anybody else who wants to wear? Anybody who wants to attempt to this? Well, I would write here, please note, none. None of the two, KF ring or Wilson's disease, none cause visual impairment. So that was a googly, right? So this is how the questions are asked. So none of the two, neither KF ring nor sunflower cataract, they do not affect the vision. And then you have to tell me, when we talk of the KF ring, where is copper deposited? So copper is deposited in which layer of the cornea in KF ring? Now tell me, copper is deposited in which layer of cornea has copper deposition? It is the, yes, Rohit, you're right. It is the Descemet's membrane. It is the Descemet's membrane. It is the Descemet's membrane layer of the cornea, which is copper deposition. So when we talk of KF ring, please note the KF ring starts from the peripheral part, superior or inferior to begin with, and then it encircles the entire cornea. So whenever we talk of Wilson's disease, it is a disease of copper metabolism, where what happens to serum ceruloplasmin? What happens to serum ceruloplasmin? It is reduced, and it is associated with hemolytic anemia, Coombs negative hemolytic anemia. Right? So this is Wilson's disease, hepatolenticular degeneration. And what is the drug of choice for Wilson's disease? The drug of choice for Wilson's disease is D-penicillamine. And the alternative that we can use here is trientine. Right? So this is Wilson's disease, hepatolenticular degeneration, which is a disease of copper metabolism. And the ocular findings are that is there's deposition of copper in the Descemet's membrane of cornea, which is called as the KF ring, or there is copper deposition on the in the lens, which is depicted as sunflower cataract. Remember, I again repeated, none results in visual impairment. None of these two result in visual impairment. All right. If brain involved, then definite KF ring. That is an indication, but neurological involvement in 95% patients of neurological involvement will have KF ring. It's not 100%, it's 95%. Okay. Is that clear, Rohit? So it is 95% of patients who have neurological disease will have KF ring. Okay, it's not 100%, it is 95%. All right, this is simple. Bitemporal hemianopia indicates that the lesion is at. So now if you see here, the temporal is gone, the temporal is gone. So what does it indicate? It indicates, it is very simple. It indicates the lesion is at the level of optic chiasma. Why optic chiasma? So now you have to tell me why optic chiasma, what is actually being affected when we talk of a bitemporal hemianopia. What is being affected? Yes, so these are the nasal fibers. Let's quickly go through it once before we proceed further. When we talk of the okay, so when we talk of the fibers, let's quickly see. So this is what I have marked as the nasal part, and in black is the temporal part. So let's quickly revise the visual pathway. So this is right and this is left. So basically we have the nasal fibers as well as the temporal fibers which get together to form the optic nerve. So once these fibers, they go behind as optic nerve, they pass through the various parts of the optic nerve and come to lie, they cross over the cavernous sinus, they cross. So the nasal fibers, they decussate at the level of optic chiasm. They decussate at the level of optic chiasm. So only the nasal fibers, they decussate at the optic chiasm and they cross on the other side. So here this is the optic nerve, here this is the optic chiasm. So what happens is, from the optic nerve, the nasal fibers decussate at the optic chiasm and they go behind as running as, what do we call it? This is called as the optic tract. So they run in the optic tract. Please remember, the optic tract always corresponds to the contralateral visual field. So the optic tract always corresponds to the contralateral visual field. By that I mean the right-sided optic tract corresponds to the left-sided visual field. Let's see how. By this I mean the right-sided optic tract has the right temporal fibers which see here, and the left nasal fibers again which see here. So remember, optic tract and posterior, they all correspond to the contralateral visual field. From the optic tract, then they go to, from the optic tract, they go to a mushroom-like structure which is called as the lateral geniculate nucleus. So from the LGN, they travel back as optic radiations. So from the optic radiation, they terminate in the primary visual cortex, or what is called as the striate cortex, or what is called as the Brodmann area number 17. So this is in gross the visual pathway. So right from the eyes, it forms the optic nerve. The nasal fibers decussate, they form the optic chiasm, which run posteriorly as optic tract. From the optic tract, they go to LGN, which is the lateral geniculate nucleus. From the lateral geniculate, the optic radiations they pass, and they ultimately terminate in the primary visual cortex or the striate cortex or the Brodmann area number 17, which is in the occipital cortex, So again, we come down to this. So which is another important topic? So another important topic which is very, 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 very important is the visual pathway and its lesions. We forgot the ones. Here you have to learn about the systemic diseases. In systemic diseases, you have Marfan's syndrome, you have Wilson's disease. I'll just write down, I forgot to mention here. So when we talk of the systemic diseases, which are the important ones that you should know? There is Marfan's syndrome, there is Wilson's disease that you should learn about. Then there is myasthenia gravis. Then there is important is the Horner's syndrome. These are some important ones which you should know, and pregnancy and eye. So these are the important ones which you should know. Then I have told you the venous occlusions, the arterial occlusions. I forgot to mention the topics here. The venous occlusions and the arterial occlusions. So these are important topics. In short, I mean to say the vascular diseases, which will also has hypertension, diabetic retinopathy, and so on. Venous and arterial occlusions, right? So these are the important topics till here. All right. Then we come to this is again, I tell you, amblyopia comes again and again because this is covered in pediatric ophthalmology, in neuro-ophthalmology, and it is so frequently asked. We discussed this in last time also and here also. Let's see. A 10-year-old child is diagnosed with amblyopia in one eye. What will be the best treatment? This was asked, and let's see. Is it occlusion therapy? It is observation, refraction with near vision, or it is radial keratotomy? Let's see. What is the answer? Tell me. 10-year-old child. Please pay attention. He's asking about a 10-year-old child with amblyopia in one eye. I already told you we discussed about amblyopia. So what is amblyopia? Tell me. What is amblyopia? The answer, you said refraction with near addition, and there are some people who say answer is A, which is occlusion therapy. So there is division there is some confusion here. Let's talk about it. So then again, I tell you the important topic here is amblyopia and refraction. This is very, very important. So basically, when we talk of amblyopia, what is amblyopia? Please note down, amblyopia is a unilateral or bilateral reduction in best corrected visual acuity when there is no organic cause, in the absence of an organic cause. Right? There is no organic cause. There has to be decrease in vision, which can be unilateral or bilateral. So when we are talking of amblyopia in a 10-year-old child, what are the options that we have to treat amblyopia? Please listen here. So the amblyopia, what are the types of amblyopia? The types of amblyopia can be refractive, it can be strabismic amblyopia, or it can be visual deprivation amblyopia. Visual deprivation or stimulus deprivation amblyopia. Right? So when we talk of refractive amblyopia, the most common example that we know of is, yes, it is without an organic cause. The most important is refractive errors. It can be unilateral or bilateral. Once there's a difference in the refractive errors, that is called as anisometropic amblyopia. So whenever we talk of an isometropic amblyopia, so what do we have? We have the treatment as glasses. So the first thing is there has to be refraction which needs to be done, and with refraction the amblyopia treatment is given, which is occlusion. And the important question, occlusion of which eye? Occlusion of which eye is done? Now you have to tell me, occlusion of the amblyopic eye or occlusion of the normal eye? What is done here? Tell me. So I'll modify this question. If there is a right eye amblyopia, so what will you occlude? You will occlude the right eye or you will occlude the left eye? Very good. We occlude the non-amblyopic, the normal or the good or the better eye most of the times. Why? Because we want the amblyopic eye to take better work, to work more, to come into focus more. So we occlude the, yes, it is alternating. It's not alternating classically, but we most of the time 1:6. That means we occlude for 6 hours the good eye, the normal eye, the non-amblyopic eye. And we make the amblyopic eye come into action, come into work. So when you have a refractive amblyopia, which can result in isometropic amblyopia or ametropic amblyopia, so the treatment here is you have to do a good refraction and occlusion therapy. The other thing that we have is strabismic amblyopia, when there is a squint. So once there is a squint, the treatment would be again. So when we are talking about strabismic amblyopia, the treatment would be glasses and surgery. And surgical, obviously you have to correct the, so strabismic, again it comes down what kind of strabismic amblyopia. It can be associated with EZO. If it is with EZO, does it have a hypermetropic eye? What is the refractive error? So the first thing would be you have to do a refraction, along with once it is left, it is whatever part is left, you have to treat with surgery. So that is strabismic amblyopia. Last but not the least, what we are dealing with is third. The third is the visual deprivation or a stimulus deprivation amblyopia. That is most common cause of a visual deprivation, a stimulus deprivation amblyopia is cataract. So again, in that case, what you have to do is you have to operate the patient, right? So last but not the least, the one thing which is left with for the treatment of amblyopia, what we can use is what I have drawn here is drops. So this is the pharmacological way of doing this. So the pharmacological way of doing the occlusion is by using atropine. Why? Atropine is a cycloplegic, is a mydriatic. So what you have is it paralyzes the accommodation. So you're not able to see something which is near. So again, what is this drop signifying? It is the occlusion therapy, but pharmacological. So it is atropine. So now you know what is the treatment of amblyopia. So now again, when we come to this question, a 10-year-old child is diagnosed with amblyopia in one eye. First thing is, if it is, and they have not mentioned what is the type of amblyopia. So in such questions, let's see options one by one. It says occlusion therapy. This any day would be the answer. This any day would be the answer. So answer is A. Let's see. Observation. No. When you have a 10-year-old child who's already amblyopic, observation is not the answer. So we cross it. No. Refraction. Yes. Partially correct. Refraction is correct, but no near addition. We are not talking, the question is not mentioning squint. The question is not mentioning anything, whether it is EZO, it is EXO. It has not mentioned anything. So why would you want to give a near addition? Had this been only refraction, I would have considered it my first choice. But when it comes with near addition, it is not the answer. And last but not the least, RK. RK is nowhere concerned with amblyopia, so it is not the option. So now you get to know. So what is the correct answer? The correct answer is option A, which is occlusion therapy. Please remember the answer, if what you're attempting is not asking you multiple choice answers, if it is just asking you one answer, you have to mark the best answer out of all. There might be two answers which are correct, but the better of the two has to be marked. Is that clear? This should not be a confusion. Ma'am, this was also the right answer. This was also the right answer. This might be, but they always prioritize your answers. All right? Always prioritize the answers. Time limit. All right. So I think what you need to ask me, Dr. Swami, is the time limit till what we can treat the amblyopia. Is that what you're trying to ask me? The time till what we can treat the amblyopia. Is that what you need to ask me? Is it that time, or is it the age that you are trying to ask? Till what age do we treat it, or till what time do we treat it? What are you trying to ask? I'm sorry, I haven't got it. Anyways, I'll answer both the questions. So when you talk of age, initially it was said that try it as, whenever the patient presents to you. So the literature has even mentioned trying it till 22 to 24 years of age. But any day, the prognosis or the results with amblyopia therapy are better when done earlier, right? So yes, you were asking me age, so that I have answered. So anytime you get, whatever time they come to you, you have to give a trial of amblyopia treatment. But the literature still says anytime till 22, 23. But also it is more effective till it is done during the developmental years, right? So even if they ask you 22, 23, you have to give the first attempt of refraction with occlusion therapy. But yes, the earlier it is, the better it is. Is that query clear? Is that all right? Is that okay? All right, so we'll move ahead. Okay, a 64-year-old male complains that he has difficulty seeing at distance, but can read the newspaper better than before. What is the probable diagnosis? So now, this is easy yet a little tricky. Let's see. Now tell me, a 64-year-old male has difficulty seeing at distance, but now he can read the near clearly. So this is what we call as what do we call it as? This is the yes, this is called as the second sight, or it is called as the second vision. This is called as this is not presbyopia. This is not presbyopia. Now you have to tell me, where do you get to see this? Where do you get to see this? Even before I come to these options, can you tell me what kind of cataract are we talking about? So this is not presbyopia. What we're dealing with cataract. What kind of cataract? Immature cataract. Further, what kind of immature cataract? Just excuse me for a minute. Just think over and I'll be back. I'm so sorry for this disturbance. I'm so sorry. All right, so we are back. Okay, nuclear cataract, good. So I would specifically call it as nuclear sclerosis. So when we talk of nuclear sclerosis, so when we talk of immature senile cataract, we have nuclear sclerosis, we have cortical cataract, we have posterior subcapsular cataract. Whenever we talk of nuclear sclerosis, what is happening in nuclear sclerosis is there is density of the nucleus increases. There is brown discoloration, so there is increase in the refractive index of the lens. So here, whatever confusions that you had, so this is because of the change in the refractive index of the nucleus. So this is the index myopia. Is that clear now? So whenever we talk of nuclear sclerosis, there are changes in the refractive index of the lens. There are changes in the refractive index of the lens. Hence, this is called index myopia or the second sight, and that is seen in cases of nuclear sclerosis. What other things do you get to see in nuclear sclerosis? So I said one is second sight, or what is called as the myopic shift, or the myopic shift, or the second sight, or the second vision. Number two, there is increase in the refractive, that is because of the increase in the refractive index. What do we get as the index myopia, myopic shift. There is a second sight, and there is also difficulty in color perception, that specifically is during the towards the blue end of spectrum. All right, so that is nuclear sclerosis. Now coming down to the other options, when we talk of curvatural myopia, which disease do you get the curvatural myopia? So curvatural myopia is when there is change in the curvature of the refractive surfaces. You know, we have two refractive surfaces, one is cornea and one is lens. So where do you get to see curvature myopia? Where do you get to see curvature myopia? It is in, example is keratoconus. Axial myopia. Axial myopia means when there is increase in the axial length. Lenticonus, all right. Astigmatism, not really. Curvature myopia, then it would be, when you say astigmatism, it will be myopic astigmatism. Simple myopia or compound myopia. Right? Absolutely. Then when we talk of axial, then we talk of increased axial length of the eyeball. And when we talk of positional myopia, we talk of the position of the lens. Anterior displacement of the lens leads to positional myopia. Is that clear? Is that okay? All right. Coming down to this. Now, a female presents to the OPD 3 years after cataract surgery and complains of painless progressive diminution of vision. Remember, last session also we did of a similar thing when a patient comes to us with a decreased painless diminution of vision little time after the surgery. So, it is again something which is very similar. Slit lamp evaluation shows the below image in the foveal contour is maintained on OCT. So this is the point of difference. This is the point of difference. Remember, there we had the foveal reflex was absent, or foveal reflex was dull. But here it specifically mentions that the foveal contour is maintained on OCT. So what is the probable diagnosis? Posterior after cataract. Absolutely. This is the answer is very simple. It is after cataract, or it is also called as PCO. It is called as posterior capsular opacification. And please remember, this is the most common cause of reduced vision years after surgery. Right? So what you get to see, you should always remember there are two types of this. Is the posterior capsular cataract has two variants. What are the two variants? It can present as Elchnik pearls, which is seen in this image when you have these globules, or it can present as Soemering's ring. right? So posterior subcapsular cataract, PCO after cataract, is the most common cause of reduced vision after cataract surgery, and it can be of two types. It can be present as Elschnig pearls or soim erasering. And as you have already answered before I could ask it, yes, the treatment is you do a YAG capsulotomy. So what kind of a laser capsulotomy is done? It is an ND-YAG capsulotomy. Can anybody just write down the full form of ND-YAG laser? That would be so beautiful if you can answer me. What is the full form of an ND-YAG laser? Tell me, what is the full form of ND-YAG laser? Neodymium. Very good. So I think there's some printing error. One is neodymium, and what is YAG? Okay, tell me what is. So it is not neodymium. No, it is neodymium, yttrium. Anybody who wants to attempt? Anybody who wants to attempt? No? It is neodymium, yttrium, yttrite, garnet. Okay, so that is ND-YAG laser. All right. So now we come down to what is image A? What is image A? It is a symptom. It is a symptom. What is A? A is colored halos. A is colored halos. Now, all that you have to tell me, the differentials of the colored halos. The differentials of the colored halos. Yes, it is colored halos. Tell me the three differentials of the colored halos. Very good. One is glaucoma. I would, further put it as acute congestive glaucoma. Then what did you say? You said cataract. Very good. And you said conjunctivitis. So now the question asks you, how do you differentiate between them? Conjunctivitis, very simple. You do a liberal wash. Once you do a liberal wash, if it disappears, if the colored halos disappears, it is because of conjunctivitis. Why? Because of the accumulation of the discharge. But how do you differentiate between these two? Tell me, how do you differentiate? Acute anterior uveitis would not give you colored halos. It does not specifically give you colored halos. So how do you differentiate between acute congestive glaucoma and cataract? And that's the last question for the day. You have to tell me the complete name of the test. No, it will not work. It does not. What does Finchem's test? No. Tell me the complete name. Meiosis, no. Meiosis doesn't give you colored halos. No, 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 no. Tell me, I want the complete name for this Finchem test. Anybody? Okay, I'll start writing. You also write. Let's see who writes first. It is Amsley Fincham stenopic slit test. So basically, what you do is you take a slit and you pass through the eye. Right? You pass through the eye. It is Amsley Fincham. Now, everyone who's watching this video, write it down in the chat box so that then you don't forget what is the complete name. It is Amsley Fincham stenopic slit test. Right? So what you do is you take that slit and you pass through the eye. If this breaks, if the halos break, that is seen in cases of
cataract. But in glaucoma, the halos all will remain uniform, right? So very good. I have at least one person who's written the complete name. I'm so happy to see that. All right. So this is acute congestive glaucoma, which is uniform edema, so it will not break. But whenever you have cataract, it will break. So with that, I finish. All right. I'll just take this one more. You have to identify what instrument is this. What is this? This is the last question. What is this? Tell me. Oh, I have so many listening to me. Good. I'm happy to hear that. Just tell me, this is the last question of the day. And then I close my session with the last quote. Tell me, what is this? This is Medox. So you have these cylinders which are placed like this. So this is Medox rod. So I finish up here with the small saying which says it is often the small steps, not the giant leaps, that bring about the most lasting change. And what are we looking at? We are targeting something which is still a bit away from us, but what we need is those small steps to keep the consistency going, right? So with that, I will sign out. Again, I would just give you a reminder that on June 29, on June 29, 6 p.m., we meet to learn about ophthalmic equipments. This would be a session of this would be a series of sessions which would be taken on. This will be on the Unacademy app, and this is a free class. This is a free special class which is on 29th June, 6 p.m. You can go to the Unacademy app and set the reminder for this class. So we meet on 29th of June, 6 p.m. to learn about some of the ophthalmic equipments. And this will be a series of sessions which I would continue till we finish all. Right? So till then, thank you so much for being with me. It was fun learning together. And this is the best way. We interact, we make mistakes, and we learn more. Till then, I'll sign off. Take care. Bye-bye.